The STOMP study was a series of studies. It consisted of 11 sub-studies that were designed for patients with relapsed refractory multiple myeloma who entered on various combinations of selinexor with other drugs as part of management. And what we presented was one sub-study within those 11 different arms. In this particular abstract, we present one of the sub-studies of STOMP, taking a look at selinexor in combination with carfilzomib and dexamethasone for management of relapsed refractory myeloma. The idea is that, of course, because myeloma is a disease that's ultimately incurable, patients have exposure to a lot of other agents, including immunomodulatory drugs, proteasome inhibitors, anti-CD38 monoclonal antibodies, etc. And so patients with relapsed myeloma were eligible for STOMP, and STOMP particularly a look at this combination of carfilzomib with selinexor dexamethasone. The nature of our abstract and presentation was to specifically look at patients with triple-class refractory myeloma and look at also how they compare to triple-class treated myeloma, but not necessarily refractory, in those who were treated with selinexor, carfilzomib, and dexamethasone. So there's already an approval for this drug. It has a very unique mechanism of action, and so does not overlap the mechanism of action of a proteasome inhibitor like carfilzomib or a steroid, which obviously induces apoptosis by direct delivery into the nucleus. We compared this triplet therapy in patients with triple-class refractory myeloma and in patients with triple-class treated myeloma. There were 12 in this study who had disease that was refractory to these three classes, and 23 who had been treated with with triple-class agents. And we compared the safety profile and efficacy in these two groups of patients. And we actually found that the adverse effect profile was quite similar, regardless of whether one had had triple-class refractory or triple-class treated disease. There was a pretty high incidence of thrombocytopenia, but grade 3-4 cytopenias, thrombocytopenia was really about the same in the two groups. There was nausea present in both groups, with high grade only in one patient with triple-class refractory and two patients with triple-class treated myeloma. With respect to other toxicities, such as decreased appetite, weight loss, gastrointestinal or pulmonary toxicity, there was really no evidence of a distinct signal as it applied to triple-class refractory versus triple-class treated myeloma patients, all of whom receiving selinexor, carfilzomib, and dexamethasone. The overall response rate was 2/3. The clinical benefit was identified in 3/4 of the patients in this small study. The time to response was a month, and the progression-free survival was on average 13.8 months, and the duration of response was a year. And so this compares favorably to other triplet regimens directed to patients with relapsed refractory myeloma who have triple-class refractory disease. So I think if we increase the number of patients, we will have built a regimen that is effective for triple-class refractory myeloma.